So today we will be talking about what happens into the function. I think COVID brings us many things. It makes us the appreciation for life. It makes us reorganize our ideas. It makes us think that we need to be able to create a better future for the next generations. We became mass addicted, and we now know the value of freedom. Now, I think this changed our lives. But I think also this pandemic gives us the opportunity to increase too much knowledge. I have the opportunity with my partner, Hamid Nassery, to create something that we call Talk About Occlusion, where I invite a great group of friends, people that inspires me, people that build up in my career, different clinical alternatives and thinking process, that I was able to digitalize it, everything. All this information is still available in my channel in YouTube. If you guys go and want to review different philosophies of occlusion with different thinking process, but with the same objective, thinking the human body as a total entity. I think when we're going to talk about function and we need to talk about the structure, we need to come back to the past, and we need to remember that bone doesn't have a memory of shape. Since Nicholas Andre in the 70s to Dr. Wolf in the 80s, we know that form depends exactly on function. And this is something that we need to consider, because every time that we change a mandible position, we start a treatment position, we're gonna influence the shape of that structure. It's a really important concept to consider. We need to remember that we function based in a stimulus. Every time that we're gonna make a movement and a stimulus, we're gonna have the liberation of hormones, cytokines, that is gonna affect the multipotent cell. And this is gonna have the potential to differentiate, to create cartilage or to create bone. And that also happens even in the embryo, that we need to start be able to develop in the temporomandibular joint. Every time that we talk about remodelation, it's not an isolated factor. It's a combination of all the different systems, starting for the lymphatic system, the irrigation system or the vascular system, all the way to the neurological to get to the muscles, and then has an affection into the bone structures to be able to create a remodelation. And it's something that doesn't just happen in one time of life. It's something that continues to happen about all this remodelation into the bone structures. When we talk about remodelation and stimulus into the bone, and we talk about function, it's impossible to not talk about the enthesis. Enthesis is that connection between the bone and the muscle that allows to create a stimulus that is going to create bone formation. And we have different types of enthesis. And this is a really, really important subject, because this is how we make the stimulation of the growth. And this is how the body responds just from the embryo all the way to development, and never stop in life, because this enthesis can keep affecting the entire system to develop different remodelation. When you come back to different stage of formation, and we have to remember that the temporomandibular joint is something that starts really, really early into the development. Many authors started talking about the formation of the temporomandibular joints for the 4 week. Many other authors, they say that about the 8 weeks, but many statements, they can demonstrate that in the beginning of the formation, we have totally two different entities. When we have the condyle that is lateral to the mecal cartilage, that is going to be the one that is going to create the formation of the mandible in the future. So if we see this sequence, we can see that the condyle is totally isolated of the ramus. They two different entities with independent vascularity and with a huge amount of potential to have different qualities of enthesis that is going to make that condyle is really going to be really susceptible to remodelation for good or for bad. And that's always the concept that we've been talking. And other authors, they describe this process in different stages. When we start for the formation with the condyle by itself, the disc start forming, and then we start with all the all the vessels and nerve formations around. That is what is going to create the differentiation. But only in the 24-week we're going to have the emulsion and the connection between the ramus and the condyle to create, and to the cartilage of Merkel, it will make the total integration of the mandible. This is another article also that shows the different stages prior to the entire process of fusion. And that's why we need to have as a consideration the capabilities and the deformations into the temporomandibular joint, that they're really susceptible to the proper balance and the physiology of the neuromuscular and masticatory system to create a stabilization into the chain of the old bones. The lateral pterygoid is one of the muscles, and this research is really new and really amazing information, that it shows how the lateral pterygoids, they have 3 different types of entasis. And that's why we have different types of condylar remodelations. And if we compare the condyle with another structures of the body, we can see this huge amount of potential and the different areas where the condyle can be reabsorbed, that can be used in a physiological way to create a stimulus of growth, but also that can be affecting the shape during different treatment positions if we don't pay attention to this. It's really important to understand the structures that we have surrounding the temporomandibular joint, because many of the symptoms that we have with patients are related with this close connection to this important structure, vital from the early stages into the embryo all the way to the maturation and when we age with time. We have the condyle that is really close to different important structures. We can see here the condyle, the petrotympanic fissure, the malleus bone, and we can see all this connection that when we have the condyles in a compressed position, it can create inflammation into these elements internally that is not just going to affect the audition, that also is going to affect the balance of the body. But the most important is to understand that that condyle has the capabilities of movements in 6 dimensions in the space, and they will have the capabilities to reshape around these compression areas. And that's why in the biofunctional dynamic principles, we try to find the more decompressed position and the physiologic position when we have hemostasis of the muscles to be able to reduce this trauma against the temporomandibular joint. Growing is really important, and it's not just happen into the embryo or in this type of a connection when the condyle by itself is connected to the ramus. We have different stages when we create different facial growth, and we have specific centers of growth through the body that it will create the differentiation and the morphological changes that will affect the function in the future. Many authors have been described, like Enlow, start talking about what is the different growth aspects into the face of the human body. And we know that the body grows by opposition and reabsorption. But we have 2 different kind of movements. We want that is the produce of this operation into the body, that the cells, they start removing and we move to one side to the other one by reabsorption, osteoclast, and by the osteoblast creating a new remodelation of the bone. But also we have growing of the face by a transposition, because we have sutures that they will mature and they will grow and they will create the advancements of these facial structures. We need to remember what Sischer says. He says that 4 important sutures into the face will participate into the facial growth. And this is really important because the maxilla, it becomes the garage of the equation, where the mandible, it will be the car that will be feed, and they need to have some symmetrical growth factors. They need to grow in harmony. So we have the frontomaxillar suture, the zygomatico-maxillar suture, the zygomatico-temporal suture, and the pterygopalatine sutures, that they will continue growing to a certain point that will create the movement of the maxilla and allow the proper growth. In the other end, we have into the mandible, into the condyles, centers of growth, into the angle, and what we can see into the different arrows, we can see the different amounts of growth that it happens to compensate the facial growth into the maxillary arch. This is the beauty of nature. And muscles became big part of the equation because, as we say, it's really important that the muscles stimulate the function and the formation of these structures where everything is going to be surrounding around. We know that the muscle has a really important function for the mastication, but we need to remember that they're not isolated. They have the capability to work with a really important organ like the tongue that is going to help us to facilitate the homeostasis. Only when the orbicularis oris and the muscles into the face, it will help to keep the equilibrium and to be able to control the balance. But these functions are involved in another important functions like the swallowing patterns, and that's why with the infrahyoid muscles, they start playing a huge role. But we cannot forget that the skull is supported by the muscles into the cervical spine, and that's why the musculature and the balance of the cervical spine, it will dictate the proper position of the head. But the cervical spine is coupling and function with the other rest of the body. And we see how major muscles like trapezius and the posture in general, it will create the entire integration to create the proper analysis of the function and the proper movement into the patient. From kids to aging, from female to male, we have different variables into the growth, and it's different transformations that not always has good result. The loss of balance of the musculature and the neurological system, it will make that this alteration into the proper growth will affect the function, and that's what we're going to focus in the future. Here, we can see that they have a beautiful dentition, like we consider, because the shapes are perfect. We see abnormality into these patterns. We can see an abnormal lateral shift into the patient when the patient speaks. We can see that is not the presence of deciduous spaces, so we're not creating a space to accommodate the permanent teeth. We can see how the patient has crowding into the lower teeth, that it shows that the function is creating trauma and is creating micro movement into the teeth. And we can see how the masticatory muscles and the movement of the mastication is creating vertical patterns that is not the normal physiology of the kid to allow the proper development of the face. Paying attention to the posture as an important component, we can see how this kid here is showing us another signs that they're really important. We can see how one leg overlap on top of the other one, that is creating a short leg syndrome. In the other pictures and videos, we can see how the long leg is always trying to extend apart to try to compensate the proper balance. But as far as we insinuate the patient to correct the posture, we can see this overlapping into the knees and into the legs that is starting a change of the generation or imbalance all the way to the masticatory system. This is the way that we need to see patients in an integration, because the real function is the integration of the entire units as an entire unit. And this not only happening to the kids, we have adults that they has been corrected with orthodontic treatments that technically has been covering and masking the reality of the growth of the patient. Here we can see the integration to the software of the images, how the cervical spine doesn't have the proper alignment, how we have the spinal process of C2 rotated, what is creating an improper imbalance of the head. But also we notice how the hyoid bone is not concentric with the other structures of the body, what is also is going to create influence into the swallowing patterns into the patient and the airway. Here we can see the patient, the posture, the inclination of the head, the shoulders in one side higher than the other one, and the imminent problem that the patient has into the knees. Also, we're gonna see how the patient is gonna create opening and closing, and we can see deviation and strength and inclination of the teeth based in a orthodontic compensation that is trying only to think in the alignment of muscles, the alignment of teeth, without taking as a consideration the muscles as an important factor to keep the harmony over different process and times in the growth of the patient.
orthopedics, a really beautiful way to help you to grow.
The Professor Pedro Planas gives us a great legacy with the concept of the tracks of Planas, with the concept of neuroocclusal rehabilitation that really counts the neurological stimulus to be able to create proper growth. I've been passionate about functional orthopedics. One of my mentors, the Professor Wilma Simoes, and my biggest mentor and teacher, the Professor Patricia Valero, who's been working with my partner Hamid Nasri and myself, develop projects to be able to create more motion in America to know the value to treat kids in an early stage. This is a patient that we can see here a mixed dentition. And it's many important factors that the temporary dentition and the mixed dentition tell us about how it's going to be the facial growth. We just need to be good investigators to see all these factors, to understand what is the alternatives of treatments that we're going to be doing and implying to be able to develop proper faces that is going to facilitate the proper masticatory movements and the proper posture. Here in the temporary dentition, we can see an inclination to the linguals of the upper teeth. That is telling you that the kid never developed properly into the volume. The sagittal and anteroposterior development didn't occur in the way that it's supposed to be. Also, we can see a decrease into the curvature, what it tells us that with the normal steppings of growth of vertical dimension in kids, that happens twice. One, when we start having the eruption of the first temporary molars, and then the second one, when the first molar come into the mouth, we can see that this kid wasn't stimulated for that stage. That's why we see lack of space that is going to limit the alignment of permanent dentition. That's what we see, the crowding. But also we notice that the temporary teeth, they never wear off. They never create the proper function. That tells us that the impulse into the masticatory system doesn't went all the way to the face to be proper developed. And then when we're not aware of this condition and we move to an S stage, where we go to orthodontics, the orthodontics is going to camouflage the problem and it's not going to let us see what is the capabilities to continue helping the kid to grow properly. This patient, these pictures are taken after the braces has been removed because we decided to intercept the case with orthopedics and forget about orthodontics at this moment because we're still having such a huge potential and growth and development of this phase to compensate this class 2. Here we can see that the first molar, it didn't grow to an ideal vertical dimension that it helps us to entrap this overbite that we have. And that's what we're going to try to intercept. So we've seen that is no breakage into the temporary dentition, so is no function and activation of masticatory environment to develop the facial growth. So this is the analysis of the case of the patient. We can see that in an habitual occlusion, the mandible is really distalized. Point A in reference with point B, it shows distalization. We also can see how the condyles are really distalized into the fossa and how the patient is developing a micrognatic profile that need to be intercepted and stimulated by the enthesis with the pterygoid muscles to develop a more anterior position and a stimulation of the growth of the condyle that is going to help us to develop better harmony. Also, we can see how the anterior teeth, they were flared for compensation into the ortho treatment, but we know that we need to make a maturation of this maxillary arch to be able to compensate and create facial harmony, to create the mandible and the maxilla to compete in an ideal relationship that is going to facilitate the function, the airway, the speech, and the position of the tongue, that is all the alternative situations that we need to consider. The direct tracks of Planas is our first resource that we use to utilize digital technology. I think the application of digital technology that I have at this moment is the proper integration of all the principles over years, utilizing the more advanced technique to be able to analyze the cases. These are the tracks. You can see the tracks in place, how they create freedom of the movement, a stimulation of the working size and the balancing size, what is going to make a stimulation of the condyle that the mandible is going to translate to, and then the masticatory chewing cycles will help to develop the development of the cheek malar process. We can see that the overjet is a lot, but this is only the first phase of the stabilization. This patient, we will be put in bimaxillary appliance by functional orthopedics that is going to help us to create the stimulus. We break the treatment into stages that I will mention later. That is the stabilization stage, where we really remove all the nociceptive input for the pathological occlusion. We break the occlusion in the kids with these tracks, and into the adults, we made it through orthotics to change the patterns and be able to develop from there. This is the first case that I'm going to show. That is my daughter, and this is when we start the teeth in eruption. We can see the overbite of the patient, not deciduous spaces, a full deep bite, retroclination of the teeth, narrow arches. When we see the function and the patient open and close the mouth, it's always the tendency to create a trajectory that the mandible want to move more anterior. They want to move more forward because the patient is trapped by his own occlusion. Perfect shapes in kids is a bad sign. Unfortunately, the beauty of the kids is the proper wedding facets that we can associate in adults like a bruxism, because we need to create this stimulus of movement. We took bite registrations into the kids in different ways, and we put appliances that is going to induce the concept to see how it's going to be the response of the kid. The first part of this treatment, we started with what we call friction plates. And basically, we're trying to start creating proprioception into the anterior teeth and desocclusion into the posteriors to allow the proper natural verticalization and the growth of the basal bone. Dr. Rocavaro helped me into the treatment. We put the direct tracks into the patient. You can see how we break down this overbite that we have. And now the patient is developing proper chewing cycles. Since we started treatment, my daughter stopped snoring, and all the different problems that she has involving the posture that we were creating, some rotations into the cervical spine. In combination with the tracks, we always have to use different appliances that will stimulate the growth. And this is one of the ways that I involve my daughters to be in love with dentistry, just make it play with the toys. This is the temporomandibular joints of my daughter. Look how the joints into the kids are different than the adult. My daughter has been trapped by the occlusion, and that's why we have not enough development of the fossas and into the condyles. Remember that when we just burn, or condyles eminence are really flat. We don't have a proper development of the anatomical TMJ yet, because the function of the masticatory muscles is the one that is going to remodel that condyle to be able to have different angles and inclinations. And this development has been positive, or it can be negative in an environment that is going to create problems into the future. So this is the analysis of the joints. Here we're going to see a video of the evolution of the growth. Look at the initial CBCT, where it shows how the condyles are really distalized and seated back because the occlusion. Look at the cervical spine has been turned, and how the hyoid bone is not in the right position. That's why occlusion into the early stage, correcting for a deep bite to a treatment position and going through the different stages into the direct tracks, we can see the maturation of these arches. Here, with technology and the overimposition of images, is the best way to analyze and break down the paradigms of the orthopedics, that now we have the facts to see how the basal bone and everything is growing in harmony. It's no more subjective concepts anymore in dentistry. We have technology today to measure all the different possibilities from static conditions to movement. And this is the application. I think the pandemic helped us to rediscover ourselves. And I think we rediscover that the future is about prevention and interception, and not like we all been doing, trying to work in corrections in later stages. Here is a case that it shows this case. Into the left side, into the CO, we're gonna see the position of the patient when the patient is biting down. We can see discrepancy into the spaces. One condyle is more distalized than the other one, and the anatomy of the condyles by themselves, they're different. This is a patient that overgrowth, being a 40 years old, has been influenced to pathological development and a non-interception of something that it happens that it create that the condyles, they were trapped by the occlusion, that they the dominant factor into the triada. This is what is going to create that we have asymmetries and problems that is going to help us to develop pathologies into the joints. In this side, this is the biofunctional bite, a bite that we take under different concepts that I will show in a little bit, but we can see how this position now has more harmony into the space. Now we will be able to put the joints into a new position that it will facilitate the relation into the system. This is what we call joint 3D relation. Now, if we integrate these images with the new development that we created with Nemotech, we creating a digital articulator that for the first time is taking as a consideration the temporomandibular joints. And here we can see with the overimposition of the planes, the different alternatives of position, not just the initial condition, the events that happen to the treatment position that we create. This position that you've seen here is the position that we're gonna start the treatment. We're going to start putting an appliance into the patient to develop muscle ingrams, to decompress the joints, to balance the system, to improve the airway, and to improve the general posture of the patient. This is what technology can do these days. This is digital dentistry applied to function. So stay tuned for the new development that we're going to have. The new technology is amazing, and I'm really pleased with this integration. And I'm really grateful with Nemotech for the opportunity to be working with them for 3 years as a clinical consultant to be able to develop all these clinical protocols and the integration of such an amazing tools that we have today. But what is your records today? I think when we talk about dentistry, people think that records is a clinical exam, maybe some periapical x-rays, and maybe some photography. Digital records are more. Digital records is to understand that the body is an entire unit and need to be treated in different segments. So we break down this diagnostic into what I call the 7 steps for diagnostic. So the first one is going to be the structural analysis that is going to tell us what is the compensations of the patient. This will help us to tell what is the posture. The second one is the analysis of the reflection of the face that is going to give us the information about the internal structures of the cervical spine, what is rotated. But in order to compensate the static condition, we need to move into the dynamics of the cervical spine with movements, and then dynamics of the mandible to be able to make an assumption of where those temporomandibular joints are. What happened into the disc? What is the congruence of this surface? What happened with the dyskinesis of the mandible? And what happened into the timing in the trajectories in movement? Then we have to make a structural analysis about position, size, and the condition of the corticals of the temporomandibular joints, because it's a good indication of what is happening. If we have an active joint disease, it will show us, and how the coupling into the condyle, into the fossa, will tell us how traumatic is the occlusion that we have. In combination with that, the analysis of the models, we will show where facets and areas that when we put together with the other records, it will tell us exactly the cause, what is creating the problem. But we cannot forget the facial-driven planning is not just for a smile design. Facial-driven planning is a condition that will drive the analysis of the patient to find out if we have really facial asymmetries, if we have facial asymmetries that they have different origins, and we cannot be confused. The dynamic of the movement of the lips is important for harmony, but we need to make a deeper analysis because we're thinking in orthopedics and development that is really important this time into our treatment plans. The first case that I'm going to show is my grand partner and friend, Dr. Professor Mariano Rocabaro for Chile, a physical therapist that has been doing research with me for over 12 years, that we have the opportunity to develop many concepts together through the utilization of this advanced technology in a thinking process that we call biofunctional dynamic occlusion. That is the recognition of the entire body as an entire unit before we get to the temporomandibular joints. And in order to make this analysis, we create integration of data. But the digital technology today allows that we can create digital analysis of the bones in motion. But it's not just the movement of the occlusion, it's deeper. We're going to be able, with this technology, to be able to see the movement inside the joints with vectors, with the precision that will allow us to describe different events that can be beneficial or pathological during the motion and dynamics of the patient. The first part of the analysis goes into the static conditions. We will see where the condyle sit, how they are, how is the cortical. If we have some interference into the bone that is creating abnormal remodulation, how is the shape of this condyle compared the right to the left, and how is the position also related with to the right to the left, but we involve two other factors, the position of the occlusion of the cervical spine, because everything needs to work as an entire unit. So this is the value to see the analysis into the static condition. But then we need to start thinking deeper, and we need to see how these structures are related with occlusion, what happened into the temporomandibular joints where those condyles are positioned, what is the inclination of the eminence, what is the position of the condyles, and it's really important right now, how is the airway of the patient in that mandibular position, because our therapeutic position always need to enhance the airway of the patient. Many concepts in dentistry recognize and know the mandibular advancements are one of the alternative ways to treat the sleep apnea. We recognize that in orthopedics, facial growth goes anteroposterior. But only in dentistry, one concept goes in a different perspective. That is the distalization of the mandibles and try to retrude mandibles in patients. This is the concept that we disagree in biofunctional dynamic occlusion. Here, we start making the analysis of the patient. This is a normal opening of this patient. We can see patterns when the patient open and close that it shows like an S pattern. We can see how the condyles in opening and close, they're not going out of the socket equally. We can see how it's a different timing of trajectories of this process of opening and closing. But the most important part that we will see is this arch of closure that has an S pattern, because we have different components into the mandibular trajectory. Biofunctional dynamic occlusion focus mostly in range of motion, in the trajectory of closing and not in the trajectory of opening. When the structure are properly aligned into the temporomandibular joint, the arc of closure need to be clean and need to project a trajectory that is need to be without this S pattern compensation. And this is what we're going to focus in this topic. And we're going to go step to step to the different analysis that we can be done when we use jaw trackers in real time to see analysis. And we're going to focus most into the joint. We've seen the teeth movement because that's the mechanism that happened. But let's focus into the kinematic traces. That is the one that is going to help us to create diagnostic. Into the movement into the jaws, if we just think into the teeth, yes, it's a good source of information for analysis. But if you want to go deeper into the temporomandibular joint dysfunction analysis, you need to go to the analysis inside the joints. Here we can see how the chief side and the working side, they have different vectors, different trajectories, that it shows laxicity of the joints, but also it shows occlusal interferences. Here, we're going to start seeing, for instance, the protrusive of the patient. And look at that deviation that is happening when the patient protrudes. Also, if you look deep into the joints here, look at the S patterns that it happens, that it shows that the joint is losing integrity into the motion, that it can create articular issues that we lose the integrity between the disc and the condyle. So we start making deep analysis. Every dysfunctional patient, we start for static conditions to masticatory solutions and analysis that we can see that the trajectories can be affected by dental interferences, but also that the muscles has a big part into the equation because they will become fatigued and they will be affecting the motion. The joints start getting distracted, creating pivot effect that is going to be affecting, and in many patients, depending on the susceptibility of the patient will develop symptoms. Notice how the joints, when they execute mandibular moving cycles, they go in different 6 dimensions. Look at the interocclusal space into the posteriors and how this mandibular chewing cycle, it has an anteroposterior trajectory. That is where patients start breaking the teeth because their bite is not supported into the posterior teeth. They need to be taller, but for some specific reason in growth and development, and in many patients just because dentistry or extractions or premature losing of teeth, we're going to have reaccommodation and we're going to have these breakage of harmony between the upper and the lower teeth. Phonetics are really important as well. We always use phonetics to analyze what I call the freedom of speaking. That is sound that compromise in, at least in English language and Spanish Latin language, the S sound to the more protrusive sound into the mandible position. Different than the F sound, that the F we will make the lip go between the upper and the lower teeth. That will create a dancing sound between the F and the S. That is when we're gonna define what is gonna be the structural reposition of the patient. But phonetics are really important. But for many years, being around Dr. Roccabaro, we understand the concept and the importance of the 50-50 law, the reaction of the mandible into the cervical spine and the reaction of the cervical spine induced by mandible position. So this trace that you've seen here, Dr. Roccabaro is making a full head extension, and what the movement that you're going to see here into the mandible is not the mandible moving, is the cervical spine moving, what create an anteroposterior dancing that it shows how the glenoid fossa can be moved against to the condyle and how that will move, shows freedom. That it shows that that temporomandibular joint has the capability of keep the congruence and move around 6 different dimensions of space. So when we make an extension, this is the position that in physiology, the mandible goes more distalized naturally without the influence of any hands to distalize to create any record. In the flexion, it's something opposite that happens. When the patient look at the floor, we have a decompression of the mandible, and the mandible has this tendency to gain anteroposterior space. This is one of the techniques that we use when we're going to take bites for sleep apnea patients. We don't want to overcompensate the patient with a protrusion. We want to find a physiological position stimulated by the normal patient to get a position that is more anterior but is more physiological accepted. Now, it's studies that show that the mandibular masticatory muscle doesn't work by itself. So it's not only the mandible what it moves when we create motion. The head has a compensation. That's why we come with a concept that we describe as a craniobite, a bite registration that I developed about 10 years ago. When we're trying to find out a neutrality into the mandible position, creating a head rotation in one axis with freedom. The patient, we will create an axis of rotation like they have a hinge around the head, and the gliding is going to create anterior and posterior rotation. Pay attention to this dancing back and forth of that mandible in a free of envelope. This freedom of envelope is created exclusively by the gliding of the craniocervical structures. The mandible is having a response with isotony of movement without taking into consideration the dental interference. And that's why we use it as an initial record to analyze the influence of the cervical spine in mandibular movements. But also, we're aware that we have muscles that over time, they will create fatigue. And fatigue is a denomination to show that the muscle fiber is changing in length. Is creating the saturation of the bridges of actin and myosin that create the sliding of the muscle to be saturated with lactic acid, what is going to shorten in balance the muscle fibers while we create torque. So we use transelectrical stimulation, transelectrical neural stimulation through the utilization of TENS to stimulate the 5th and the 7th cranial nerves to relax them and allow the muscle to oxygenate in combination to create a mandibular trajectory that it will give us as a result a decompression of the temporomandibular joints because the muscles will become more relaxed. But this is a technique that also need to be taken as a consideration with another thinking process, conservative, to understand that we need to preserve the integrity of the package into the temporomandibular joint. We need to keep the joints functional as a closed pack. And that's why sometimes just neuromuscular concepts, they, in certain aspects, they don't pay enough attention to what happened into the temporomandibular joint. In biofunctional dynamic occlusion, we make a correlation between these two factors. We use the muscles, but we also understand that the joints need to be packed. We understand that we need to have congruence of the joints with freedom, but packaging the joint through the anterior wall of the eminence. So this is the biofunctional position in an static position. As you can see, is nothing between the teeth besides the bite registration that we test and we take the first CBCT for the first bite analysis. We can see here how the posture of the condyles has been changed. This is an initial position that need to be adjusted during the phase that the patient is going to have the splint, that is going to be an anatomical splint, that the patient has the alternative to develop muscle ingrams and function through that position. So here is the result of the motion and opening and closing. We can see how the trajectory has been improved. We can notice how now we have an arch of closure that is cleaner into the anteroposterior trajectory, that the movement of the joints, it will have a proper gliding into the different planes of analysis and how the patient has more freedom. The only thing that doesn't function at this point is the habitual occlusion of the patient. The habitual occlusion of the patient has been replaced for an orthopedic device that we call it orthotics. Now, we're going to make an analysis between the two positions. We're going to have 2 minutes. Okay, so I need to speed up. I'm going to take like 5 more. So we make an analysis of the airways to see when we control, and then we put the appliance in place. That is what is going to help us to see opening and closing. And we can see how the ingrams goes right there to that position because the patient can hold the occlusion into that mandible position. Now, the difference between the two trajectories is one that is supported by the occlusion, the other one is not. And this will help that the patient can be stimulated and stabilize it, because sometimes this shift is what will create compression of the occlusion. So it's really important concept. We just need to remember that we don't want to compress joint. We don't want to create artificial paths of movement by creating a hinge axis rotation that doesn't exist into the patient. Mostly when we have uneven condylar conditions, like in this case. It's important to understand that the harmony of the arches, it also will affect the movement. We can see how this patient has been missing one teeth that orthodontically has been closed and how the structural dynamic has been changed internally. Multiple articles define the connection between cervical spine, harmony of movement, this displacement when we don't have proper relationship. Hundreds of patients has been studied between static conditions in habitual occlusion and treatment position, and we notice that all the cases, they have different discrepancies. we need to remember that we have different potential of treatments depending of the treatment that we're gonna do. Orthodontia is different than orthopedic. Combination with skeletal anchoring, MARPE appliances, and orthodontic surgeries are the different options. We have the technology today to plan digitally all different kind of cases to facilitate the orthodontic correction or the orthopedics, having guide surgeries to be able to have a better analysis and be more predictable through maxillofacial surgery that also can be properly planned to see what is the changes that we can do to develop a proper relationship between the car and the garage, in proper relationship, and also to avoid cases like this one, when the teeth are being taken out of the bone because traditional methods of growth appliances that has not been taken as a consideration, the functional and the connection with the enthesis, that is the traction into the conducts, would create the proper face analysis. Biofunctional dynamic occlusion keep all these concepts together. In the last minute and a half, I will show the entire case starting from finish, from the beginning to the end, where integrate the analysis of all the different phases into the patient. We can see how we start from the patient being overclosed, how we stabilize the patient with an orthopedic appliance that we call orthotic, that it has anatomical shape, that the patient had developed ingrams, to mock-ups, and the development of the posture based in the 7 concept of analysis of diagnostic, how step by step we checking all this evolution into the function of the patient, the phonetics, the lateral excursions, and all the analysis we repeated in different stages, even when we utilizing the appliances. Look at the correction of the posture, look at the correction of the dynamics of the head movement. We really can tell that when the system is in harmony, it's a big improvement of the general condition. This is the gap that we feel. This is the last patient that I treated in France in my clinical foot mount case. When we make a non-preparation case in a physiological position and we were able to reestablish the aesthetics. We finished the case with enamic material. This is a transitional phase. We're gonna finish the ceramics later, but at the time, the patient is in a full mouth rehabilitation, made it with enamic material, with good aesthetics, with good function, and this is the integration. This patient is actually in Germany, so this is how I send me records. And the importance of the function, the mastication, is something really, really important. So I just want to finish with this. What future you want to create for your kids? I think we can have a beautiful future if we think that it's important to create prevention and interception and allow the kids to be able to create and grow properly. Thank you so much. Have a wonderful rest of the day, and I really appreciate this opportunity to be sharing all these opportunities with you.
3 questions from the chat.
Okay. 3 questions for the